Hey, good evening. My name is Brandon Johns, and I'm going to be your paramedic instructor for this block of instruction. Today, we're going to go over setting up invasive pressure lines. So this could be anything from arterial pressure lines or CVPs or PA catheter pressure lines. So anytime we need to measure the pressure from inside the body through a catheter. So typically, you'll see this in a critical care setting, maybe in a critical care transport where you're moving a patient from one hospital to another, and the patient has a lot of invasive lines. They may have a PA catheter coming out of their neck, or radial arterial line coming out of their radial artery, and they may be on a ventilator and on a lot of pressors. So this isn't something you may see in the field on 911 calls, which you probably won't, but anytime, you never know when you're going to get put into a situation where you're transporting a patient from one facility to another. So at those times, you will probably run into these, and knowing how to either set them up or manage them is very important, and it is a paramedic skill, and I believe every paramedic should be familiar with this and know how to use it. So for this course, for this block of instruction, like I said, I've got some materials here. I've got a bag of normal saline, 500 mLs, a pressure bag that you may have seen in trauma cases, a arterial line setup, and a pressure cable. Not all monitors are capable of doing these. Most Zoll's monitors have this capability. Some life packs do. So it really just depends on your monitor, and you don't see many Philips monitors out on the streets anymore. So, but if you have a Zoll, it should definitely have a pressure line on the side of it, maybe labeled P1 or P2. Also, for this block of instruction, I do have a checkoff, and for this checkoff, there are some I would say critical failures, some things that you need to be very aware of and very cognizant of when setting these up. So you may come into an ICU setting where you need to transfer a patient to a higher level of care, and they may have just put an arterial line in, and they may ask you, hey, can you set up the arterial pressure line for us? Or it could be, like I said, a CVP, a central venous pressure, or a PA catheter. So when we get started, the first thing we want to do is verify what fluid we're using. There's a lot of different fluids you may see in critical care and in that environment. We want to make sure that it's normal saline. Right now I'm standing in a cath lab room, and a lot of times in the cath lab we use heparinized saline. That can also be used. It's a very low dose of heparin that goes through the line, and that can be used in arterial lines or in balloon pumps. Anytime you have a pressure line, you may see heparinized saline. So don't be alarmed. It is something that can be used. But typically we used 0.9% sodium chloride normal saline that we have on the street. Your pressure bag here, this is a 500 ml. They make these in 500 ml and 1,000. On the street, you probably see the 1,000 bags, the 1,000 pressure bags, infusers that go with the 1,000 bags. For this setting, we're just going to use the 500. Next, this is probably the scariest part that people are worried about or afraid of, and the most complicated part, but this is your pressure tubing. This pressure tubing is like IV tubing, but it is much more stiff, and that'll come into play later when we talk briefly over the pressure monitoring and how your tubing can affect it. We won't go too far into it, but we'll keep it within the scope of this presentation. So we want to take our pressure tubing, open it up. This one's already out of the package. It'll be in a package. Usually you have a couple of paper ties. Take that off. You have two portions. You have the patient, the side that goes to the patient, and then the spike bag the spike that you spike to the bag, just like any other IV tubing. Pull your tab, spike your bag, just like you would any other IV. Open your roller clamp, and then move down here to the middle portion. This is called the transducer. This is what reads the pressure. We're going to turn the stopcock so that it's off to the patient and open to this side port. The first thing I want to do is de-air this bag, and we call it burping the bag or de-airing the bag. Either way, it doesn't matter. So for this one, there's either some kind is a squeeze tab. This one is a pull tab. You can see a blue tab that you pull here. This allows you to move fluid through the line. So we're going to burp the bag. So I just hold it like this. I pull the blue tab and I squeeze the bag. And this will slowly get the air out of the bag. I want all the air out of the bag. And then fill the chamber, the drip chamber, about halfway. This bag is now burped. Now I'm going to take this bag and put it here in my pressure sleeve on the hook. And then I'm going to inflate this bag. We'll continue to squeeze until we get to a green indicator. Below the green is a red. Gone too far, it's nothing to be worried about. It'll be fine in the end. But we just try to go to the green. That's 300 millimeters of mercury. That's important. Why 300? Because that gives us enough pressure to overcome the pressure inside of the patient. So the standard is 300, and that's what the green mark takes us to. So now we're going to take our pressure line and get the air out of it. I have the stopcock off to the patient. It's off to the patient. This is a vented cap. We can leave that on. And then we can pull the tab, and that will allow fluid to move through the transducer. At this time, what I will also do is tap the transducer just to make sure there's no air. If you have any air bubbles in your transducer here, it can cause variations in your pressure waveform that you're looking at. Once I have all the air out of the transducer and out of the side port, I flip the stopcock off to the side port. It is now flowing toward the next stopcock. So next when I have it off to the patient and open to the side port, again, that is a vented cap, and I'm just watching for all the air to go through, and I've got fluid moving out. I can now turn that stopcock off to that side port, and finally to open to toward the patient, and do the last section here and make sure there is no air in that section. We now have a pressure line with no air in it. That most important, if somebody is on a presser, I prefer to have an arterial line. And if they have an arterial line, I'm going to hook it up. If I have a patient with an arterial line and a PA catheter and a central line, CVP, and all these different lines, and I have one cable and one port to hook it into on my monitor, I'm going to transduce an arterial line. Reason being, in transport, if your patient moves around, or if the arterial line becomes dislodged, that is an arterial bleed. They're going to bleed out, okay? You won't know. If you don't have it hooked up to an arterial pressure reading, you will not know that that became dislodged. They could be bleeding into the bed for a few minutes before you realize it. So if you have an arterial line, never move a patient without it being hooked up. That is a safety rule of mine, and I hope that you would adopt that as well. Moving on to the cable. Now you have it hooked up to the patient. You have flushed the line to the patient. You now need to hook it into your monitor. And then you're going to hook this cable into this transducer. To zero a invasive line, you have to First, you need to get this to the right point. In transport, it's very easy just to take this transducer and tape it to the side of the patient. There's a point here at the fourth intercostal space, a mid-axillary line that we call the phlebostatic axis. It is a crossing point here at the level of the heart, and that is where you get the most accurate reading, and that is where the transducer should stay. So in transport, again, you can tape it to the patient if you need to, or if you have a clip, they make clips that this transducer slides into, and then you can take your clip and clip it to an IV pole, maybe on the end of your stretcher. At either way, you have to have it at the phlebostatic axis. Next, you want to open this transducer to atmospheric air. And what that means is we need to turn it off to the patient. This is going to the patient. The easiest way to think of this is you need it open to the computer. So I'm going to flip this up and off to the patient so that the tail is always going down. I think of like a tail of a dog just hanging down. This is a tail. I always have it going down. I flip my transducer up, which is going to the patient. This is a vented cap. If it's not a vented cap, you have to take it off. You must take your cap off so that this port is open to atmospheric air. Once that is done, you go on your monitor, you find your arterial line, you simply go to the menu. There will be a 0 option. One of the soft keys will allow you to 0. Once that line is zeroed, you can then place your cap back on. If it's not vented and you had to take it off, just place it back on and then turn your stopcock off to atmosphere. So anytime you need to 0, anytime that you disconnect or reconnect that cable, you're going to have to 0. If you're doing this in flight, anytime you get to altitude, it's best to 0. Remember, you're zeroing this to atmospheric air, and when we're at ground level, it's fine. But when you get to altitude, you want to re-0. And then remember when you come back down to ground level, when you land, you want to re-0 it again. Moving on, now that we have it connected, we're going to look here. I'm going to show you some samples of arterial lines. And this arterial line, you can see that there's a systolic and a diastolic pressure that is given to us on our screen by the fluid that moves back and forth ever so gradually in that transducer, and that sends a signal, turns it into an electronic signal, and sends that back to the monitor. You see there's a systolic and diastolic. In the middle, you see a dichrotic notch. That dichrotic notch is the closing of the aortic valve. That's very important to see. And then under your waveform, your systolic and diastolic, underneath that waveform, that is your mean arterial pressure. So your waveform numbers will give you a systolic, diastolic, and then in parentheses, it'll give you a mean arterial pressure. Also on this page here you're looking at are some other abnormal waveforms. That goes beyond the scope of this video, and we're not going to go into those, but maybe we can talk about it at a later date. Also with an optimal waveform and an underdampened waveform and an overdampened waveform. Again, those go beyond the scope of this video, and we're not going to go into that, but it has a lot to do with whether your line has gone bad, say if it's a radial artery line and it has gone bad, if your tubing is too long, if there's air in your tubing or blood in your tubing, those things can change your waveforms, and you really want an optimal waveform. And maybe, like I said, at a later date, we can talk about that. Some of the things are on the checkoff sheet that I would really be concerned with would be, again, this is a placing the line. We try to do it in a sterile technique. Once the line is placed, everything is aseptic, same as setting up doing an IV, connecting your IV. So aseptic technique, not touching your spike, being aware of the ends of your line, not leaving a line laying here that can not capped, that's going to touch the table or the bed. That's not really a clean technique, and we don't want to put the patient at risk for infection when they are already sick. We don't need to make their situation worse. The other part is de-airing. That would be a critical failure. You've got to get air out of your line. I think we've talked about that enough. If you have any questions for me, please leave them in the comment section. I'll try to get back to you, and I hope maybe at a later date we can talk further and discuss more about invasive pressure monitoring. Thank you. Have a great night.